Thank you very much. I appreciate the opportunity. And let me first preface all my comments by saying that I am very glad I'm in Chesapeake. I'm telling you that my colleagues throughout the state do not have such a strong collaborative working relationship with their community and their leaders. So I'm very glad that we're in Chesapeake, and I think that our citizens benefit from that. So I'm just going to run through a brief thing. You've heard about COVID. I don't need to repeat a lot of the stuff that you've seen and heard in the newspaper and on Facebook, but in case anyone should question, this is COVID-19. The thing I do want to emphasize, it is novel, meaning it is totally new. We have no previous experience with this virus. We have a lot of experience with flu. I use this comparison, people understand it. You know, flu is kind of like someone we know is kind of like your cousin you don't like, but every Thanksgiving they come to your house for dinner. You may not like them, you know how they're going to behave, you can predict how they're going to behave, and you know what, they behave that way. And flu is kind of like that. We know that, but we have absolutely no experience with the COVID-19. It's totally new. So we're learning as we go along. So I want people to appreciate that. We certainly are using sound epidemiological principles from many, many years of experience, but that is a lot of the reason that has contributed to some of the concern because we have no experience. Now, what does that mean? And what is COVID-19 and how can you get it? Well, you probably know it as well as I do. You get it by people who are symptomatic, they're coughing, they're spreading the droplets, and anybody can get it. One of the reasons anybody can get it is because this is new, we have no herd immunity. So there's no protection from it. The elderly appear to be at greatest risk. Those with chronic disease appear to be at greatest risk. So what we are doing is basically to protect this high-risk population, but it involves everybody. And that's certainly the most important thing. We want to move forward. What are the symptoms? You've heard that: cough, congestion, fever, and those are the criteria that we are using. Is there a vaccine or is there medicine for it? There is not at this time. Certainly there are many places that are working on it and people would love to have the vaccine come out right away. The truth is a vaccine will probably be developed while we're still in the midst of COVID. However, it requires clinical testing. It's a clinical testing that would take a while before it can be released to the public. So the truth is it would take probably at least a year before a vaccine comes out. I will say there's lots of research on medication. Actually, chloroquine, which we have used historically many years ago for malaria, is one that is on the forefront of the testing. And testing on medications we've used in the past will mean that actually the length of time to get it on the market will be less. However, I don't know if the testing for this particular medication will be the one or not, or if some of the ones that they are looking in terms of new medications. But currently we have no vaccine and we have no medication. Again, this is in huge contrast to flu because we do have a vaccine. Whether or not people take it is obviously another question. And we do have medication. So it's a totally different situation. Let's look at sort of from the epidemiological aspect. The big issue, whenever we have a communicable disease or a new communicable disease or an epidemic, there are certainly a number of different stages. And the first stage, where you like to intervene using very sound epidemiological techniques that have been proven to work time and time in the past, would have been to do testing on lots of people, be able to find who is positive, be able to quarantine that individual, to be able to do class case finding, contact tracing, and to be able to get them out of circulation as well so that we could prevent the transmission of the disease. Unfortunately, the test kits were not as readily available. They're still not as readily available. So the limitations on who is being tested is more directed towards those who have symptoms. They're certainly working on getting more test kits, but right now that is limited. So far in the United States, there have been 85 deaths. I would tell you that probably, if you go turn on the radio, that number will be different because it's constantly changing. So don't take this as a final result. And to be perfectly honest, it's not the number that's important. It's for us to understand trends and for us to see if disease transmission occurs. And this is where, in many respects, Chesapeake has an advantage right now, and I want us to build on it, and I want us to capitalize on it. This is the key. You have a chart here, and you have on your presentation, but again, just since we prepared this presentation this afternoon, the numbers have changed. As of, well, driving here and listening to the radio, there are 62 cases. Someone has said now there are 67 cases. But again, it's not the number of cases that's important. It is how they're getting them. Is it community transmission? The 4 cases in Virginia Beach, for example, that we know of, do not have been primarily related to travel. They've not occurred because of community transmission. Peninsula, on the other hand, has had community transmission. Vitally important because we are ahead of the game right now. We don't have community transmission. Cases in Virginia, again, I just mentioned it, and we've had 2 deaths, again, on the peninsula. We've had no confirmed cases here in Chesapeake. So that, again, gives us an advantage that we want to capitalize on. I want you to see the trend, not so much the trend, but the timeline of our responses, what we have done in doing this. And again, what you will see on this is that we are working with all city departments. We're working with all within the community. And this is a real standout for Chesapeake. It seems almost like an obvious thing because we've worked so well with the city in hurricanes in the past before, and the EOC and the Unified Command and the Joint Information Group. We've done those things in the past before. And so pulling it together was easy because we're all used to it. So I don't want anybody to take that organization and that cooperative relationship for granted, because I can assure you it does not exist throughout the state, and it is putting us ahead of the game. And it's what we've got to rely on this, because we can't rely on vaccines, we can't rely on medications. We have to rely on what we do as a community and what individuals do. And that's what I hope that you'll walk away with, is that we are responding in ways that we hope can get people to do that. The next page we're talking about, I mentioned that the tests, because of limited numbers of tests, are not available for everyone. There are some requirements in order to be tested. So we are beyond the original phase. I want to show you why we're in this mitigation phase and what makes a difference. What you see before you now is a graph from the 1918 Spanish flu pandemic, done by the National Academy of Science, very credible, very reliable source. And what they looked at is they compared 2 cities, Philadelphia and St. Louis, and they looked at, again, it's the trend as much as anything else, of the number of cases that occurred. Philadelphia was very slow to implement social distancing. Sometimes we don't give some of these actions because they're not as fancy as MRIs or fancy technology, but from an epidemiological perspective, they're extremely effective. Philadelphia was very, very slow to implement their social distancing. St. Louis, on the other hand, implemented it right away, the social distancing. And what you can see from the curve is the incredible difference in the number of cases. Huge surge in Philadelphia because they were slow in implementing. This was the 1918. We want to model what St. Louis did. That's what we want to do here in Chesapeake. And it requires a concerted effort of everybody. We've been working with the city manager, we've been working with communications with restaurants, we've been working with the schools, we've been working with daycare centers, with prisons, with jails, with community events. This is an all-out city engagement. It's not any one department responsibility. If everybody in the city doesn't buy in, we're not going to be successful. And that's what we need to do. Again, this is called a community mitigation strategy. One goal, prevent person-to-person transmission. That's the goal. That's what we want to do. And if we can prevent the person-to-person transmission, then we can bring this to an earlier close, and we can protect those who are at highest risk. Most of the people perhaps in this room may not be as high a risk. Risk, again, relates to over 60, relates to having chronic disease. And again, people say, gee, do we really have asymptomatic people who are just spreading it? The data is still out there. Some say yes, some say no. So we won't know until this is all over. Some people say that those who have been considered asymptomatic were symptomatic, but it was very mild. So we have to, right now, focus instead on just being sure people are not put in positions where they might be exposed. So what does social distancing look like, which is what I'm just now talking about? And the general recommendation is 6 feet. Now, some will say 5 feet, 6 feet. So what is 6 feet? What is 6 feet? You guys aren't, you're right. You're not 6 feet apart. We're not even 6 feet. We're maybe a little closer, I don't know. But 6 feet, I've given you some examples, some easy examples. It's about a picnic table. Could you fit a picnic table in between you? It's about the length of a regular dog leash, not one of the fancy ones that rolls up, etc., but the length of a regular dog leash. And a usual couch is about 6 feet. So those are sort of things you can relate it to, because who knows 6 feet, you know? But this is an effective way to try and think about how we can make the 6 feet. Now, I want to mention some things in discussing this because, as I said, we've been involved in communicating today with a lot of community entities to see how we could implement social distancing, how we could take into account not only businesses, but families, because big questions have come up. And I have my staff here if you have specific questions in terms of epidemiology or organization or operations. But some of the more frequent questions relate to daycare centers and to restaurants. These are things. We've sent out communication to restaurants. I don't want restaurants to close, but I want them to protect their staff and to be safe for people who use a restaurant. I mean, I get all my days mixed up now because I have been every day at the office, but one of these recent days, I just called in an order, went, picked it up, went home. There was no contact whatsoever, but I still got to eat what I wanted to eat. So we are encouraging restaurants to push more for that operational model of takeout, grab and go. There are many different names it goes by, because we don't want them to close if we can avoid it. They're businesses. They're valuable for our community, but I also don't want their employees or the community to be put at risk. They can also have in-house, but we want to put it down to small numbers and to have appropriate distance. So this letter was sent out today. We're working with daycare centers so that we can, again, they can have criteria for admitting people into the daycare. We're even going to purchase, and we recommend it to them, the infrared type temperature thing, so that they could take the temperatures of people before they come in, staff and children, so that we provide an environment that permits parents to work. We have essential people who need to work. We have healthcare providers, we have public safety, we have people who are central to business operations. So we need to provide a way in which they can, but again, we want it to be safe for all concerned. So we've sent out communications. Epi, Lisa, and I are on call 24/7, and people are invited to go ahead and call us. I'd prefer not at 3 in the morning, and I know she'd prefer that not as well, but we are on call 24/7 because we are here. Our purpose is to protect the community. That's what public health does. That's why we are here. And the truth of the matter is, people would say, oh, if we have no cases, or oh, if we do well, then what was all the hype? I would say, what we did worked. That's what we want. So the absence of something is really what we want. That's what we're working for. So I want to thank the entire, I guess the last one is just sort of things that we are trying to address. We still have a lot of things that we need on the sort of package. We meet on a regular basis. We have our HDOC, and if any of you, feel free to contact any of us at any time. I think most people know how to contact me, and as I said, Lisa and I are 24/7 available. We're here to protect the community. And the staff is here if you have any specific questions for them. Thank you.